Have you guys ever met someone who is convinced they smell terrible, but when you ask people that know them well and people that are around them all the time about the smell, nobody's able to provide any evidence for it? So I recently had an opportunity to treat a patient who felt just this way. This individual became so convinced of their terrible odor that they were emitting that they refused to go to their acute partial care program any longer. They believed they were offending the driver and that the driver for the program would no longer come to their home and pick them up on a daily basis. Now, of course, when you spoke to staff and you spoke to peers at the program, there was no evidence of any type of odor being emitted. This is a very rare syndrome that sometimes occurs on the borderline between psychosis or delusional disorder and OCD, and it's called Olfactory Reference Syndrome. Now, this is a rare psychiatric condition when somebody is completely convinced that they smell bad. This often leads to intense shame, it leads to anxiety, and of course the person socially withdraws from things like their day program because of the way they feel. Now, it was first noted in Japan in the 1970s, and again, it's often associated on the spectrum somewhere between OCD and delusional disorder. Let's talk a little bit about the core features of olfactory reference syndrome. Now, of course, the core feature is going to be a preoccupation with odor. It's a persistent belief that I smell bad, my sweat smells bad, my breath smells bad. Whatever the case is, there's this preoccupation that I am emitting this odor and other people are offended by it. Now, of course, when you go to look for objective evidence to support this, you can't find any. You, the clinician evaluating the patient, doesn't smell anything. When you talk to friends, family, and other people that are around the individual all the time, there is no identifiable smell. Nonetheless, these people experience extremely high stress and distress from the situation. They feel extremely anxious, they feel shameful around other people, and of course, they naturally withdraw from the social environment because of how they are feeling. Now, you can see other core features as well. Patients may exhibit repetitive behaviors. If I believe I'm emitting this odor, I may be obsessed with showering or changing my clothes, for example. If I believe my breath is offending people, I may use mints or gum or other ways of masking this perceived odor. I also may use excessive amounts of cologne or perfumes and deodorants. And of course, I'm going to be constantly checking with others about the situation. I want to know, do I smell bad? Can you smell that? I'm worried about it, right? These are going to be core features that we're going to look out for. And these people are going to avoid social interaction. They're going to avoid any place that puts them in a close, confined area around other people. That could be many public settings, including places like school, work, or relationships with significant others. They're going to withdraw from all of these, and it's similar to what happened to my patient, where this patient felt excluded from the day program and no longer wanted to attend. Let's talk about the epidemiology of olfactory reference syndrome. Now, I said before, it's quite rare. It was first discussed in the 1970s in Japan, and we don't really have a very clear understanding of what percentage of the population suffers from this particular syndrome. However, what we do know is it often starts when people are younger, usually in adolescence or early adulthood, and it doesn't necessarily have a predominance for male or female. It pretty much affects both equally. Let's talk a little bit about the treatment of olfactory reference syndrome because I think it's extremely important, and we'll start with the pharmacotherapy. So remember I said that this disorder lies somewhere on the spectrum of OCD and delusional disorder. So you might be thinking of the common medications to treat OCD, such as the SSRIs like fluoxetine or sertraline, to be good starts for the OCD-like symptoms. If you think it's more in the primary psychotic disorder realm and more delusional disorder, you're probably going to take a dopamine modulating or dopamine blocking medication such as aripiprazole, risperidone, or olanzapine, to treat that particular symptom. Now, I can tell you, in my experience, delusional disorder is incredibly difficult to treat with medication alone. And we often need combination therapy, possibly sort of the same way you would treat MDD with psychotic features. You might go with a SSRI medication along with a dopamine modulating or dopamine blocking medication. So there are also options for psychotherapy. Now, just like in OCD, things like exposure and response prevention are going to be helpful when it comes to talking about these odor-related compulsions. You also might consider something like cognitive restructuring. So essentially, in cognitive restructuring, we're going to challenge the distorted belief about the odor. We're going to continue to ask that person to put that theory on trial and show the evidence for why they think it's happening. And hopefully over time they can develop some insight that this is not really happening, that it is really more a part of their mind sort of playing tricks on them. You can also do social skills training so that they can focus on properly socializing again. Now, the supportive measures you're going to want to engage in are going to be psychoeducation for both the patient and the family. You want them to know about what this disorder is, what its course typically will look like, and of course what the treatments are going to be. You would also want to address any other comorbidities such as anxiety disorders, depressive disorders, and encourage gradual reintegration into their social programs such as an acute partial care. Now, I think this is a great example of another rare but also challenging situation for patients and clinicians. It's a powerful reminder that mental illness isn't always visible. Sometimes it's a phantom only the patient can sense or feel.